Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for having me in this meeting. My name is Samih Odhaib, an adult endocrinologist and diabetologist at the CAR Specialized Diabetes Endocrine and Metabolism Center. My presentation today is about the diabetes remission, the path of remission from the chains of diabetes to the symphony of life. Every journey begins in the shadows, but some ends in music, light, and life. This is the story of remission. I have no conflict of interest regarding this presentation. Our learning objective for this presentation is defining updated consensus criteria for the diabetes remission, including the subtypes of remission, understanding the pathophysiological mechanism enabling remission in type 2 diabetes, reviewing the evidence-based intervention regarding lifestyle, pharmacological, and surgical intervention, identifying the predictors of and strategies to maintain long-term diabetes remission, and finally, analyzing a real-world integrated case study with an in-depth rationale behind every clinical decision in the case. Let's dig in the remission. The first question that came into our mind, can we put diabetes in remission? According to the Standard of Care in Diabetes 2025 by the American Diabetes Association, the diabetes remission is defined as the glycated hemoglobin, hemoglobin A1C less than 6.5, 48 millimole per mole, which was sustained for more than or equal to 3 months. I insist, it's 3 months, not years, without a glucose-lowering medication, any glucose-lowering medication, or equivalent level via fasting glucose or CGM when the hemoglobin A1C is unreliable. This is so different from the old definition of diabetes remission. Let's dig in the history. The historical evolution of diabetes remission. In 2009, the ADA consensus statement, which was used until 2021, the earliest definition distinguished between the partial, complete, and prolonged remission, in that the hemoglobin A1C less than 6.5%, the fasting plasma glucose between 125 milligram per deciliter for at least 1 year without medication. This is called partial remission. It was 1 year. For complete remission to be achieved, we have normal glucose level and the hemoglobin A1C in the normal range, the fasting plasma glucose below 100 milligram per deciliter for at least 1 year, and also without medication. If the individuals type 2 diabetes achieve this and maintain it for 5 years at least, the same criteria for complete remission for at least 5 years without medication, it's called a prolonged remission or a durable remission. What was the difference between this definition and the newest definition after 2021? We have the threshold of 3 years. So while 3 years was not the formal threshold, the idea of longer remission duration, which was set by the older definition, which was 1 to 5 years, was emphasized to indicate sustained disease control, not to define the onset of remission. We are not talking about remission. We are talking about disease control. So that definition, or the old definition, is short-handed, while the new definition may be more broad. My friend Hassan is a typical case in our presentation. Hassan has a beautiful diabetes journey. Hassan is a 41-year-old rehabilitation nurse in our hospital, presented with fatigue, polyuria, and unintended weight gain. He came to the diabetes clinic in our hospital with a lab finding of hemoglobin A1C 8.3, fasting plasma glucose 186 milligram per deciliter, the BMI in the obesity range of 33, and his C-peptide was 2.2 nanogram per ml. So I diagnosed him as diabetes. Hassan is reluctant to use medication, motivated to avoid chronic medication. He asked me, can I reserve this naturally I'm a good guy, an athletic person. I will define the remission target, help structure his care and monitoring. So we told Hassan that there is a pathophysiology for this remission to be achieved. Roy Tyler and colleagues set the Tyler's twin cycle. In this figure, you can elaborate that excess calories intake lead to excessive liver fat and fatty liver and lead to insulin resistance. Insulin resistance lead to hyperglycemia, which in turn increase the pancreatic fat. The increase in pancreatic fat lead to beta cell failure. So we can induce remission by targeting any point at this twin cycle. Reversal begin with the liver fat reduction via caloric restriction in diet. Hassan is so motivated, and he has his liver function test and alanine transferase 62 international units per liter and ultrasound confirmed fatty liver. And he, by his own, take a fibroscan by one of our colleagues and reveal that he has grade 1 fatty liver. His fasting insulin without treatment is 28 microunits per ml, and his HOMA-IR is more than 3. So Hassan has moderate to severe insulin resistance. Hassan started diet and exercise intervention, and this clinical decision here, he will not take medication and start very low caloric diet to target hepatic fat. Let's remind ourselves what this means. Hassan is complying to the direct study. What's direct study? Direct study is led in the United Kingdom by Michael Lean and his colleagues, and they did a marvelous study, which is a pivotal study in this system. Primary care-led weight management for remission of type 2 diabetes, an open-label cluster randomized trial. They take 298 participants, and with 149 assigned for intervention with very low caloric diet, around 825 kilocalories per day, and they followed them for 12 to 20 weeks. They achieved a marvelous remission in 86% of individuals if they lost 15 kilograms. This is marvelous. Let's see their demographic data. Whether the patients or whether the individual with type 2 diabetes in the intervention group or control group, they are overweight or obese. The weight mean was around 100 kilograms. Let's see the hemoglobin A1C. It was around 7.6, 7.7, 7.5. After the intervention, as you can see in this figure, they achieved 86% of diabetes remission in the intervention group. And this remission is significantly associated with their weight loss. Hassan marvelously lost 12 kilograms in 8 weeks, which is very fast. He was on structured Iraqi adapted program, monitoring by biweekly labs and renal function and ketones. But Hassan is adapted to Iraqi adapted program, and the direct here is on the Western style program of feeding. So we search for diadem study, effect of intensive lifestyle intervention on body weight and glycemia in early type 2 diabetes, an open label parallel group randomized control trial by Tahiri and his colleagues. This was in Qatar, and Qatar style of food is just like our in Iraq. They take the intervention group and the control group and followed them for the 12 months, and they achieved about a 12 or 11 kilogram weight loss in the intervention group and 12 kilograms in the intervention group and 4 kilograms in the control groups. Similarly, they achieved around 1% reduction in hemoglobin A1C and about 0.4% in the control groups. And they achieved remission in about 61% of their individuals. Diadems show that significant weight loss, more than 15% of the initial body weight, was achieved safely by 21% of participants in the lifestyle intervention group. Weight loss was accompanied by diabetes remission in 61 of the participants. Over 30 of participants in the diadem in the intervention group had normal glycemia at 12 months. Even they didn't achieve the marvelous remission of type 2 diabetes, they achieved normal glycemia. Hassan adapted the diadem, and fortunately, it was the time for Ramadan, and Ramadan here decreases the amount of calories that was taken by Hassan, and he was adapted to suhoor and iftar, lentil, soup, salad, no bread or rice, and the rationale behind that, if you take culturally sensitive or culturally adapted food, this will improve adherence. So Hassan now in remission. He was on remission for 18 months. According to the old definition, Hassan always has normal glycemia or euglycemia. So you are in remission where your long-term blood glucose level remain below 6.5% regarding A1C and 48 millimole per mole regarding his fasting plasma glucose for 3 months or more regarding the newest definition, and the same for the 1 year for the oldest definition. This was sustained for 18 months, but now we have a problem. The problem not affecting Hassan himself, the problem affecting the world. It was COVID-19 emergence, and Hassan did not go to the gym that he was used to daily, as he is a very athletic person, because of the locked state that affected the whole world. Hassan now has diabetes range of reading his blood glucose around 200. So it's a time for an intervention. Whatever you have, a remission, which was failed, and it was sustained for 18 years and then failed, it's time for an intervention. And here, the intervention will be pharmacological. So what are the pharmacological strategies for remission, for inducing remission in Hassan case? Agents supporting remission are glucagon-like peptide 1 receptor agonists, SGLT2 inhibitors, TZDs, and short-term basal insulin. Hassan was so reluctant to use many drugs. Hassan, weight gain during the homestay lead to hemoglobin A1C rise. So I started him on semaglutide, initiated at 0.25 milligram, then titrated up to 1 milligram weekly. The response for Hassan is marvelous. Hemoglobin A1C dropped from 7.2 to 6.2 in 10 weeks. Significant appetite suppression and weight loss resumed. The rationale behind that, as was confirmed by the sustained studies and the work of Melanie Davis, which was published in Diabetes Care, that GLP-1 receptor agonist promotes satiety, reducing hepatic glucose output, and support beta cell recovery. It is ideal for inducting remission. Let's remind ourselves of the Roy Taylor twin theory about the pancreatic and hepatic fat. In the Sustain 7, which was for the differentiation between semaglutide 1 milligram and dulaglutide 1.5. Whatever the result was, the final results was for the both GLPs. The GLP in general induce remission in diabetes. See the semaglutide arm, the high dose semaglutide arm, 1 milligram. Hemoglobin A1C was achieved below 6.5 or equal to 6.5 in about 67% in the semaglutide arm, while 47% in the dulaglutide arm. Let's see the weight loss responses. More than 10% reduction was achieved in 27% in the semaglutide arm. while it's 8% in the dulaglutide arm. Whatever the difference was, and it's in favor of semaglutide. GLP-1 agonist is ideal for inducing body weight changes and remission of diabetes. GLP-1 receptor agonist, according to many studies, if we use single GLP-1 receptor agonist, we may induce 6 to 10% weight loss, 56 to 68% reach hemoglobin A1C below 6.5, and 69 to 79% reach hemoglobin A1C below 7. The dual agonist, GLP and GIP, a 12% weight loss, about 70 to 80% reach hemoglobin A1C below or equal to 6.7, below 6.5, which means remission, and marvelously, 82 to 96% reach hemoglobin A1C below 7, which is very marvelous. The triple or triagonist, 16% weight loss, 80% reach hemoglobin A1C below or equal to 6.5, which means remission, 80% reach hemoglobin A1C below 7. These are the changes that was achieved by the GLPs. Hassan is happy with his current body weight and his current A1C after 17 months on 1 milligram semaglutide and lifestyle intervention. But Hassan was so reluctant. Hassan asked me, I want to have another faster option. Semaglutide is boring. May I quit it? So I told him, our next option, though it's hard, yeah, we have the bariatric surgery. You can have bariatric surgery. We may induce remission here. There is a vertical sleeve gastrectomy, which may induce 22% weight loss and induce 14 to 86% type 2 diabetes remission. We may have Roux-en-Y gastric bypass, 25 to 28% weight loss with 50% to 84% type 2 diabetes remission. And the best is pilopancreatic diversion with a duodenal switch, which induce a better weight loss in the range of 36 to 55% weight loss and 90 to 100% type 2 diabetes remission. But Hassan is reluctant to use a drug. He will not get surgery. So he promised me that he will stick to the lifestyle intervention and resume his athletic program. Let's test our knowledge. For patients or individuals with type 2 diabetes who has relapse after remission, what are your options? Insulin, sulfonylurea, bariatric surgery referral, or just observe? Of course, according to Rapino and his colleagues, bariatric surgery referral is the best. Now, let's turn our faces to another thing. What are the best predictors for remission in type 2 diabetes patients with on very low carb diet or caloric diet? Is it microalbuminuria, low C-peptide diagnosis, earlier diagnosis within 6 months, or older ages? Of course, it is earlier diagnosis according to the direct study and its extension. What are the predictors of remission in type 2 diabetes? As you see, direct study was done in Western population, while diadem study was done in the Middle Eastern population in Qatar. For the direct study and its extension between 2018 and 2023, the population adult with type 2 diabetes less than or equal to 6 years on BMI in the overweight and morbid obesity range, key predictors for remission with the strongest predictor, weight loss more than or equal to 10 kg, short duration of diabetes equal or less than 6 years, lower baseline A1C equal or less than 7.6, fewer or no diabetes medication at baseline, higher baseline C-peptide level, which indicate preserved beta cell function, and the absence of insulin therapy. The insight here is sustained weight loss was directly proportional to the remission rate, 86% remission if we lost more than or 15 kg lost. For the diadem study, which was done in Qatar, Middle Eastern population with less than 3 years post type 2 diabetes diagnosis, age between 18 to 50, BMI is about 27. Key predictors of remission is somewhat similar to the direct study. Earlier diagnosis less than or equal to 3 years, greater initial weight loss, high baseline BMI, more weight to lose, more reversal potential. This is a common sense. Younger ages, typically less than 40 to 45, adherence to structured lifestyle program, and sticking to the ethnic and cultural tailored and family support. The insight here, we, with early intervention and culturally adapted support, led to 61% remission at 1 year. So every population has its own cuisine or its own food. Cultural consideration in lifestyle program regarding Hassan in Iraq is the social eating. We are social persons. Hassan is very social. He's a rehabilitation nurse. He has friends and always has feasts. Social eating is a problem. As Muslims, we have fasting periods. The changes in our program, food program or diet program regarding Ramadan is a problem by itself. We may have occasional late eating, especially in his night calls. He is a nurse and has a night call, and occasionally he has a late eating. So culture matched diet equal to higher adherence level and maintenance of remission. Hassan asked me lately, I'm now compliant. I'm tolerant to the 1 milligram semaglutide and I will not increase it. What if my BMI rises again or my C-peptide drops? This is a very hard question for me, really. But Professor Lean and his colleagues has an extension to the direct study and have answered this question. They followed their individuals with diabetes, whether in remission or not in remission, for 5 years. At year one, 62% of the direct extension participants were in the remission, while in the year two, 51, initially they were 86, it dropped to 62, then dropped to 51. At the end of the fifth year, they dropped to 13%. See the the proportion of remission by year, the lower left. Average weight loss was 8.9 kg, median 7.3 for those who were in remission at the year between 2 and 5. So you must maintain your body weight low. Let's go back to the Tyler's twin theory. You may have break the cycle at any point regarding pancreatic fat and the liver fat to induce the remission. Where lifestyle alone is insufficient to sustain remission, adjunctive pharmacotherapy, GLP-1 receptor agonist, and or SGLT2 inhibitors can extend the beta cell rest and glycemic control. Direct study focused on lifestyle intervention. Later literature support pharmacological adjunct to maintain remission. Hassan is not now in remission. He was in remission before COVID-19, and he has relapsed, and he is afraid now to quit his GLP-1 receptor agonist in order not to get his diabetes back. He's now comfortable with his medication. This is me. I'm saying diabetes remission is not the end of a disease. It's the beginning of a new relationship with life, with food, with hope. Let us not just treat blood sugar. Let us restore the human spirit. Hassan asked, what should I take with me home regarding from this lecture? Hassan, diabetes remission is no longer a myth. With available drug intervention and lifestyle intervention, it is achievable clinical goal in early type 2 diabetes. Earlier diagnosis and intensive lifestyle changes and weight loss are cornerstone of successful type 2 diabetes remission. Medication like yours semaglutide, GLP-1 receptor agonist type, and the SGLT2 inhibitors can support remission and maintenance when lifestyle alone is insufficient. You refused the bariatric surgery, although the bariatric surgery for some individuals remain the most effective intervention, and it's more effective than the treatment regarding cases of severe obesity or failed non-invasive strategies. Psychological support and cultural adaptation and long-term follow-up are essential for a durable remission and sustainable remission. Real-world cases show that integrated and patient-centered approach yield meaningful drug-free outcomes. And finally, future care should shift toward remission-oriented rather than the glucose-oriented diabetes management with stratified pathway based on predictors. When I was first appointed as a diabetologist and the center, my first ever publication was about a patient who loses 18 kg and type 2 diabetes mellitus, the challenges of complete remission. This is the old definition. I talked here about a male person in his 40s who have type 2 diabetes mellitus, and he cannot afford to get his medication, and he was so obese. So he lost 18 kg, not by his intent. He had a Graves' disease, a new diagnosis, and make him lost 18 kg, and then he lost his type 2 diabetes. I encourage you to read this article. I think it's a marvelous article and it's a nice article. Thank you very much. Thank you for listening. I'm ready for taking any question by you. Thank you very much.